Assalamu alaikum. I will not take you long after Dr. Nadeem session, so I will continue for the review of the gynae portion for the innovation in gynecological oncology. I'm sorry, can I have my screen up? Okay, perfect. So I'll go through overview of the cancer treatment from radiation point of view and whatever the solid evidence in gynecological malignancy, including the cervix cancer. It's really hard to deliver all this. Role of radiation in gynecological cancer, either adjuvant radiation, it can be primary, especially in operable diseases, or neoadjuvant, and we know also the palliation. So the evidence is so solid, the indication for pelvic radiation for the high risk in endometrial cancer, especially for the stage 3, is so solid, especially of the Partec 3 with the chemoradiation. For stage 1, you need to be careful for adding some risks, especially the grade 2 or 3, and if there's any LVSI or more than age of more than 60, with some risk factor as well. Also, we have to consider the inadequate surgical treatment. And here, as you can see, there are many randomized trials published a long time ago and really consistently showed is benefit in the local control as well as the metastatic-free survival, and perhaps translate into meaningful overall survival with the control of the primary. So again, the benefit from the local treatment, especially for the stage 1, we reduce the local recurrence by more than 50%. And now we're moving into more molecular classification for the endometrial cancer. I think this is the most personalized medicine so far. We started already, especially at KFMC, more personalizing the treatment for adding the type of the molecular typing, and even stage 1A we treated if they are really aggressively moved to stage 4 according to the ESTRO guideline. I already alluded to this. I don't have to go through it, and this is the changing practice for the endometrial cancer, especially for stage 3 and on. So in summary, for early stage disease in endometrial cancer, future will be like more the molecular subtyping. Carcinosarcoma also changed recently into more epithelial disease, and have to be aggressive with doing chemo, then radiation, and that's what we are doing at King Fahd Medical City as well. And we adopted the protocol because most of the evidence is really drained from retrospective, so there's no randomized trial in those type of cancers. And the most of local recurrence treated with the chemoradiation, and you can salvage them if you follow them appropriately, especially with the strict imaging follow-up. For the cervix cancer, the resident has to remember the changing in the classification. So 1B3 is not cervical disease anymore. So the surgeon may be 1B2 or less. So also in the cervix cancer, the main driver is the radiation oncology, and perhaps also with the medical oncology. And the Milan trial changed the practice long time ago by concluding radiation, especially 1B3 with the new classification, is really the main treatment. And if you add surgery and more radiation later on, you just add the toxicity. So also surgery has been struggling with even early disease. So if you have any more risk factor for the local treatment, please do not do the surgery or recommend the surgery. There's also meta-analysis for the chemoradiation from 1B3 and on with the new classification that there is more than 10% gain in overall survival, and really the local control as well as the metastatic-free survival. So I moved to the brachytherapy, either the vaginal wall brachytherapy, the multi-cylinder, the hybrid, as well as the interstitial brachytherapy. So brachytherapy is the most meaningful dose escalation in radiation medicine. So most of the failure we do is either from the radiation dose that we don't give adequate radiation dose, or the tumor location that we cannot escalate the dose, as well as if there is really challenging with the normal tissue. Surgery always eliminates the macroscopic disease, but also not good in a microscopic disease. But if you are able to escalate the dose, and might be above 80 grade, you really eliminate even the gross disease, and that can be done with the surgery, with the brachytherapy surgery. So dose was escalated in MRT, proton, SPRT, and only the brachytherapy that can give a meaningful heterogeneous dose escalation, although the more treatment with the proton and more advanced imaging system can also give a good treatment in the dose escalation. And brachytherapy is necessary, especially for the cervix cancer in terms of the local control, as well as is the overall survival. So I don't want to spend much time on the vaginal wall brachytherapy because it's so simple for us. Only 3 treatments can be delivered and without any really like prerequisite, and even without any CT scan. For the image-guided interstitial or hybrid adaptive brachytherapy, the indication for the interstitial, either the anatomy is distorted or you cannot really access the anatomy. Either there is a small introitus or there is a parametrial involvement of the disease. When you go off the midline, we're good in delivering the midline or treating the midline disease. But once it's off the midline or there is a challenge with the anatomy, we're not good at that, especially after the surgical removal of the passage or the vaginal cancer, as well as the re-irradiation and the valvar disease. So you can see this is the old applicator from the interstitial brachytherapy, Momtis, the Saad, as well as the Vienna ring that could not fit and has to be modified in a 213. But we moved and modernized the brachytherapy at our institution at King Fahd Medical City, and really needed engagement, focusing on the efficiency, experience, the manpower, as well as the quality of treatment. And we started from 2020 after the work of my colleague, and especially was developed a long time ago, the brachytherapy in our center. And thank you to Dr. Mushab Basirian, the group who really set up the practice long time ago, and we advanced the interstitial portion. And we started from 2020 by changing the application of more advanced in the interstitial portion. For the interstitial portion, we started with the multi-channel applicator, the GYN 2 years ago almost, and then we went to the KFMC lecture interstitial ovoid application or technique that you can see it. This is from the older lecture, but changed into more ovoid with more needle, and you can implant any tumor in the pelvis. We then moved to the 3D interstitial applicator, which is really a ring, and you can implant the inside ring as well as the outside ring. That way you reach more than 2 centimeters of the midline, and you can escalate the dose of the midline. We then also moved to what they call ARAS. It's small, and it can fit maybe better sometime with a small passage. And that really gives a good dose escalation or good implant, especially deep in the pelvis, and if you cannot reach to the parametria. This is the last application or move for the interstitial brachy. There is no any uterus, or the uterus is removed, and you need to implant from outside. So that's the best application for the Kelowna perineal interstitial template, where you put from outside and then you implant the whole pelvis from outside inside, and it's best if delivered through the ultrasound guidance, and that way it minimizes the complications, especially the post-treatment complication. So with the collaborative effort, as well as with the advancement of what we have in terms of technique and really continuous learning, that's really what will move the field. Thank you very much.